Thanks everyone for joining today. We're very excited to have you and to share some information with you all. I'm going to introduce our three speakers today, Dr. William Rutala, Dr. Curtis Donskey, and Kathleen McMullen. They'll each individually be sharing some slides and sharing their own personal discussion on today's topic today. And to go ahead and kick things off, Dr. Rutala, would you like to take it away?
Yes, thank you very much, Peyton, and good afternoon. It's a pleasure to be here to talk to you about a very, very important topic. In fact, I think what we're going to discuss today is the most important change in disinfection and sterilization as far as reducing infection risk in the past 50 years. In the next slide, of course, the topic is the issue of a paradigm shift from doing high-level disinfection of flexible scopes to sterilization. In the next slide, we're going to essentially identify what I think most of you know, and that is more infections are associated with flexible endoscopes than any other medical device in healthcare. In the next slide, we'll essentially see the three things that we're going to do. We're going to talk about why we're going to do this shift from high-level disinfection to sterilization. And of course, the reason is we're going to reduce the infection risk associated with high-level disinfection by transitioning to sterilization. And then we're going to talk a little bit about the FDA and professional organizations and how they support this shift from high-level disinfection to sterilization. In the next slide, essentially, we see the Spalding classification scheme. Of course, it's very, very important. But the one thing that I wanted to mention is essentially we have not been compliant with the Spalding classification scheme for several decades. As you know, what Spalding says is that critical objects are objects that normally contact sterile tissue or the vascular system or through which a sterile body fluid would flow. Now, you know, duodenoscopes have contact with the duodenum, which is normally sterile. Cystoscopes have contact with the bladder, which is normally sterile. And bronchoscopes have contact with the lung, which is normally sterile. So these items and other flexible endoscopes should be sterilized, although for many years they've been high-level disinfected. In the next slide, we're going to look at some of the reasons for essentially transitioning from high-level disinfection to sterilization. And there are many reasons. First of all, we can comply with the Spalding classification scheme. Second, you can see there, it's evidence-based. It's based upon the fact that we have had more than 150 outbreaks associated with flexible endoscopes over the last several decades. In the next slide, essentially what we see is essentially a table that essentially summarizes how many outbreaks have been associated with semi-critical items, of course, to include the flexible endoscopes such as the gastrointestinal endoscope and bronchoscope. When this data was collected back in 2018, there were 130 outbreaks. Today, there are more than 150 outbreaks associated with gastrointestinal endoscopes and bronchoscopes. And you can see how that compares with essentially other semi-critical items in Table 2 on that slide. In the next slide, we're going to essentially continue this thought with the fact that there's no margin to safety associated with high-level disinfection. Now, why do we say there's no margin to safety? Well, the reason we say that is there are more organisms on a flexible endoscope in many cases than our high-level disinfection procedure can eliminate. That is, that our cleaning and high-level disinfection procedure can eliminate. Essentially, we have anywhere from 10 to the 7th to 10 to the 10th, which of course is 10 million to 10 billion microbes on the gastrointestinal scopes. And if you look at the peer-reviewed literature, our combination of cleaning and high-level disinfection will reduce 10 to the 6th or greater. Now, on the next slide, we see essentially an expansion of that fact. First of all, we can see on the left there, we can see complex flexible endoscopes are contaminated with 10 to the 7th to 10 to the 10th. Just as a comparison, surgical instruments after use and before cleaning contain less than 100 or less than the 10 to the second 85% of the time. So there's far, far more microbes on a gastrointestinal endoscope than there is on a surgical instrument after use and before cleaning. On the next slide, we essentially again see an expansion of that. We can see in that slide the microbial load there. Microbial load is 10 to the 7th to 10 to the 10th. That's 7 to 10 logs. Now, what the literature shows is that when you clean, you essentially reduce anywhere from 2 to 6 logs. And when you perform high-level disinfection, you reduce anywhere from 4 to 6 logs. So if you add those 2 and 4 and 6 and 6, essentially you have a 6 to 12 log reduction. Now, the problem is sometimes you can reduce as many as 12 logs, but other times you're only going to be reducing 6 logs and you may have 10 logs or 10 to the 10th. Therefore, the level of contamination after processing can be as many as 10,000 microorganisms. Of course, that occurs with maximal contamination and minimal effectiveness of cleaning and high-level disinfection. Now, of course, we're going to see the other problems with reprocessing endoscopes is the complexity of the endoscope and endoscope reprocessing, and of course, biofilms can contribute to failure of endoscope reprocessing. On the next slide, essentially, we're going to continue with this thought of margin of safety. Essentially, with high-level disinfection, we can reduce 6 logs or more, but sterilization, by definition, is a 12-log reduction. That is, to have a process cleared by the FDA, you have to demonstrate to the FDA that you can kill as many as 1 trillion spores. That's 10 to the 12th. So now we have essentially 12-log reduction compared to a 6-log reduction associated with high-level disinfection versus sterilization, where you have that 12-log reduction. So you have a 6-log margin of safety. And of course, in infection control, we like margin of safeties because, of course, it's very important to our effort to reduce infection. On the next slide, we see essentially some other reasons that we want to have this shift, to include the fact that sterilization can improve outcomes as it can be validated. We will validate these cycles using biological indicators. And of course, the manufacturer proves to the FDA that this sterilization technology is capable of achieving a sterility assurance level, or an SAL, of 10 to the minus 6. Other issues include high-level disinfectants are relatively resistant to non-tuberculous mycobacteria. You may know that there's been many outbreaks associated with use of high-level disinfectants and non-tuberculosis mycobacteria. You may know that, of course, there's toxicity associated with glutaraldehyde and peracetic acid, and there's anaphylactic reactions associated with orthothaldehyde. And of course, we all know that high-level disinfection is a complex process and prone to errors and challenges. One of the most significant studies I think I've seen is about 10 years ago, when they had certified endoscope reprocessing technicians perform 12 essential steps associated with endoscope reprocessing. And persons were watching their completion of those 12 essential steps. And when they did, there was only 1.4% compliance with those 12 essential steps. So essentially, we have errors and challenges associated with reprocessing because, of course, it's a complex medical instrument and reprocessing is very complex. The next slide, essentially, we will see the complexity of this instrument. We know that there's long, narrow lumens. We know that there is rough or pitted surfaces. We know that there are damaged channels that can impede microbial exposure to the high-level disinfectant. And of course, we know there's a very high microbial load that in many cases will not be eliminated by our traditional cleaning and high-level disinfection. In the next slide, we will see a few other reasons, to include liability arising from an unquantifiable process that results in uncertainty. Many of you may know there's been dozens of lawsuits associated with reprocessing of flexible gastroendoscopes that have been high-level disinfected. Of course, we have evidence emerging about biofilm resistance to high-level disinfectants. We have the fact that high-level disinfected items are unpackaged and can become recontaminated, whereas, of course, the terminal sterilization process prevents that recontamination. And then, of course, we have environmental contamination during drying, handling, and storage. And of course, lastly, all that's going to be resolved by a shift from high-level disinfection to sterilization, which will provide a margin of safety. In the next slide, essentially, we're going to look at some of the recommendations from professional organizations regarding this issue of high-level disinfection versus sterilization. We know from ARN that they recommend sterilizing reusable flexible endoscopes that are manufacturer validated for sterilization when possible. In the next slide, we see essentially a recommendation from AMI. And what AMI says is sterilization continues to be recommended for endoscopes. And they talk about the infection risk, and the only way you can eliminate that infection risk is essentially sterilization of these critical items. In the next slide, we see essentially some data from a guideline that was just published in April of 2025. Essentially, this is a multi-society guideline from 8 professional organizations to include organizations such as ASGE and ARN and HSPA, which of course is the Association of Healthcare Sterile Processing Association, IDSA, and so forth. And what they say is when sterilization technologies are shown to be effective in clinical settings and cycle specifications are validated and included in the manufacturer's instructions for use, facilities should begin developing an institutional process for converting from high-level disinfection to sterilization for semi-critical reusable medical devices that are associated with a high risk of transmission of infection to patients. In the next slide, essentially, we see the fact that there are many national and international organizations that now recommend sterilization for lumen flexible endoscopic devices. In the next several bullets there, you'll see that the FDA has done the same thing. In an FDA safety communication in 2021, they recommended sterilization for bronchoscopes. In an FDA panel conclusion in May of 2015, they recommended sterilization for duodenoscopes. And an FDA guidance document, or more precisely, safety communication in 2022, they said that you should not perform high-level disinfection for certain urologic endoscopes due to the failure of high-level disinfection, and they recommended sterilization. And they said if you could not do sterilization of these certain urologic instruments, you need to eliminate the use of these urologic instruments because high-level disinfection is not acceptable. And lastly, you can see FDA has promoted innovation to enhance safety. They've talked about in safety communications the use of fully disposable sterile duodenoscopes. In the next slide, essentially, we see in general the issue that although we've had guidelines and although we've had recommendations from the FDA, why has sterilization of endoscopes not been implemented? Well, the bottom line is, in general, sterilization technologies for reprocessing reusable flexible endoscopes has not been available until now. In the next slide, we'll essentially see some technology. This is FDA cleared technology for terminal sterilization of 99% of the flexible endoscopes in the marketplace. And you can see essentially the specifications of the endoscopes. But again, this technology essentially covers 99% of the flexible endoscopes in the marketplace. In the next slide, essentially, we see what we intended to do. We intended to talk about this shift and why this shift is important. And of course, this shift is important for many reasons, but most important, to reduce infection risk associated with a high-level disinfection of endoscopes, and the fact that the FDA and professional organizations have supported this shift to sterilization. So in the last slide is a real quick summary. The last slide talks about endoscopes associated with more infections than any other medical or surgical device in healthcare. We, of course, have no margin of safety associated with high-level disinfection due to the high microbial load, the complexity, and of course, the bioburden on those instruments. We have a recommendation to sterilize, which is evidence-based. We have professional organizations, at least 7 or 8 that are recommending sterilization. And based on these safety communications from the FDA, we can be assured that the FDA favors innovative designs to include sterilization for endoscopes, and sterilization offers many potential benefits. To include, it's validated. The endoscopes are going to be free from microbes. There is a sterility assurance level that is achieved when, of course, the biological indicator is negative, and of course, it's cleared by the FDA. There's improved patient outcomes, there's reduced toxicity, there's instrument compatibility, and there's reduced liability and less likely to be sued. And of course, endoscope sterilization, I believe, is a paradigm shift, the most important shift that I can think of in the past 50 years that will enhance patient safety and efficacy.
Thank you, Dr. Rutala. For everybody who has questions at the very end of the presentations today, we'll have some time to go over questions. So if you are submitting them, we'll get to them at the very end. And now you guys will be hearing from Dr. Donskey. I'll turn it over to you.
Thank you. Next slide. So I will be presenting our data on an evaluation of a new technology for terminal sterilization of flexible endoscopes using hydrogen peroxide gas plasma. So this is the Ideate Medical's Steriscope, hydrogen peroxide gas plasma endoscope sterilizer. It provides sterilization of flexible endoscopes with as many as 8 internal channels. The endoscope is placed inside a container that interfaces with the sterilizer and with the endoscope, and it subsequently provides a sterile storage container for up to 6 months. So again, the device is shown there. And prior to sterilization, manual cleaning must be performed, followed by drying with filtered forced air for a minimum of 10 minutes. The water-resistant cap has to be removed from video endoscopes. And then we do a leak test to ensure that there's no leak that could cause fluid invasion. Next. As part of the technology, a single-use channel connector and pressure differential are able to rapidly diffuse hydrogen peroxide gas plasma through the internal channels of the endoscope. Each cycle requires a total of 44 minutes, and that includes 2 injections of hydrogen peroxide gas plasma 16 minutes apart. And you can see the endoscope there inside the container. So the FDA, as Bill mentioned, has requirements for sterilization validation. To obtain FDA clearance, the manufacturers of the Steriscope were required to provide evidence of a 6-log reduction in spores with a half cycle with no soil, and then they had to do full cycle, show that same reduction with a full cycle in simulated use testing with soil. And then they also had to show that there's no evidence of damage. Next slide. So before we received the device for testing, the manufacturer told us about the testing that they had done. Sterile wires were inoculated with 10 to the 6 Geobacillus stereothermophilus spores with no soil, placed in the duodenoscope elevator channel, and 0 of 39 of those were positive. And they also provided data that an Olympus duodenoscope was sterilized 125 times with no evidence of damage to the scope. Next. So we are, why are we interested in challenging the technology? It is because low temperature sterilization technologies sometimes fail in the presence of salt and serum, which simulates inadequate cleaning. And it's essential to do this type of testing to show the importance of adequate cleaning. So here's some data from Dr. Rutala, where they used a soil load of fetal calf serum and salt. And what you can see here is that steam sterilization did not fail to reduce vegetative cells and spores to undetectable levels, and that all 3 of the low temperature sterilization technologies, however, could be made to fail in the presence of a salt and serum challenge. simulating inadequate cleaning. Infrequently with ethylene oxide and hydrogen peroxide gas plasma, but it did occur, and notably with vegetative organisms. And vaporized hydrogen peroxide in particular, as you can see on the right of the slide, was frequently failing in the presence of serum and salt, including with vegetative organisms. Next slide. And Dr. Rutala did some further investigation and discovered that really it was the salt that appeared to be the principal factor interfering with efficacy, because as you can see, with just 10% serum, there were no failures. That failure often occurred with Staph aureus or with spores when salt was present. Next slide. And in another study, Dr. Rutala and his group showed that blood on dirty instruments can interfere with low temperature sterilization technologies. So in this case, they had instruments that were uncleaned, and then they were sterilized with or without addition of blood. Test organisms, bacteria, mycobacteria, and spores. Steam, again, inactivated all organisms in this testing. Ethylene oxide and hydrogen peroxide gas plasma frequently failed on dirty instruments, and this occurred both with and without the addition of blood on these instruments. So our objective was to, with any new technology that comes out that has a claim for sterilization, I think it's important to do this type of testing to really challenge the technology, to really assess how effective it can be in a worst case scenario with inadequate cleaning, which might mimic worst case clinical scenarios. So we use chemical and biological indicators with all our testing, and those are shown here. We use the chemical indicators and biological indicators, and with the Stereoscope technology, there were no failures. They were all the chemical indicators passed, and the biological indicators. There were no surviving Geobacillus spores. So it works inside the container. So then for test organisms, we used a variety of vegetative and spore organisms. So the vegetative organisms, E. coli, of course, which we're going to be very concerned about with any type of endoscopic procedure, vancomycin-resistant enterococci, Candida auris, which can be more challenging for a number of technologies than bacteria. We included soil for all tests with these vegetative organisms. And then we used a high inoculum. So again, typically a 6-log organism challenge is sufficient for testing, but we went above and beyond the FDA requirement and used 8 to 9 logs of organisms. And then for spores, Bacillus atrophius, C. difficile, and Clostridium sporogenes, again with 6 logs or with higher log challenges beyond the FDA requirement. Next. Test soils, we use 3 different test soils in our testing, 5% fetal calf serum. We use an RPMI medium, which also has salt in addition to 10% fetal calf serum. And then we used an artificial test soil, 2015, which was developed by Michelle Alpha, and it's intended to simulate the worst possible case challenge. As you can see, all of the many ingredients in there, including 20% sterile sheep blood. So a real challenge for any technology. We used 3 different methods. So we wanted to replicate the method that the manufacturer had used. So this was inoculated steel wires, as you can see on the left of the slide there, that were inoculated with organisms, and then they were allowed to dry. Those wires were placed inside the elevator channel, and then we vortex the wires and used other methods to recover the organisms after sterilization. Next. Method 2, we followed a method that's previously been published where we inoculated the elevator recess with organisms and then the instrument channel as well, with an included 5% serum. The organisms were then flushed with 100 milliliters of sterile water to allow the inoculum to reach the center of the channel and again allowed to dry. Next slide. And then finally, we did one final super challenge where we inoculated throughout the lumen using a brush. So we inserted this brush into the biopsy port, passed it, immersed the distal tip of the duodenoscope in the test suspension, articulated the elevator mechanism, and then withdrew the brush from the biopsy port and repeated that process 3 times, and again with soil load being used. Next slide. And so our results. Next. So for vegetative organisms, I'm not going to show you any figures because they're all 0. For each test method and for all 3 test organisms, no organisms are recovered. And this is including with a very high inoculum, so up to 1 billion organisms, 9 logs or 1 billion organisms of Candidorus E. coli. We saw no recovery, and VRE, no recovery of these organisms. And the soil, again, was involved in each of those cases. For spores, no spores are recovered in the absence of a soil load. In the presence of soil, we consistently saw that 6 to 6.2 logs of spores were eliminated in accordance with the FDA's requirement that no survivor should be recovered after a 6-log challenge. When we used higher inocula of spores, greater than 6.5 logs of spores that were recovered from the control endoscopes, we did sometimes recover spores. So we were able to make the sterilizer fail with a very high level of challenge. Next. And here's some of those data. So this is you're looking at spores on inoculated wires, and as you can see, with no soil on the left of the slide, you're seeing the amount recovered in the dark bars, and then as you can see, next to those dark bars are zeros. So there were no spores recovered after sterilization of any of those spores when there was no soil present, including in the presence of 8 logs, a very large inoculum. And as you can see, with 5% fetal calf serum in the middle, or RPMI medium on the right, we occasionally had failures with Bacillus atrophius, with low-level recovery of spores after running the sterilizer when high levels of organisms were present. Next slide. And here, spores were inoculated into the elevator recess and instrument channel with 5% serum. And in this case, as you can see on the right of the slide, all 3 spores, spore-forming organisms, were completely eliminated with sterilization when the challenge was 6 to 6.2 logs of recovery from the control scopes. And on the left side of the slide, you can see that we did occasionally have failures when we had a very high organism challenge. So 7 to 9.7 logs of spores were not consistently completely eliminated. They were greatly reduced, but not consistently reduced to 0. And then here, finally, our most greatest challenge, spores inoculated throughout the lumen using a brush. And once again, you see that with a high organism burden, we occasionally saw failure. So with 6.2 and 6.2 logs of spores there was no failures. But when we had 6.8 to 7.3 logs recovered from the controls, we sometimes had low levels of failure with sterilization. Next. And so in summary, the sterilizer consistently reduced vegetative organisms to undetectable levels, even under the worst case conditions, including a very high organism load and the presence of organic material and salts. In the presence of a soil load, 6 logs of spores were eliminated, but if we had higher numbers of organisms as a challenge, they were not consistently. They were reduced, but not consistently completely eliminated. So these findings, I think, demonstrate the effectiveness of the sterilization technology. It's very effective in reducing organisms, but they also highlight the importance of meticulous cleaning of endoscopes prior to use of the sterilizer to ensure patient safety.
All right. Thank you, Dr. Donskey. And now I'm going to pass it over to Kathleen McMullen.
Good afternoon. You hear me okay, Peyton?
Yep.
Excellent. All right. Thank you, everyone. I am here to talk just a little bit about our experience in a real life working endoscopy suite with this technology. So go ahead and to the next slide, please. So we did a very small scale experiment that was really intended to introduce sterilization into our endoscopy area and just raise awareness of the technology and the implications. The goals of our study were to understand potential alterations or disruptions to the current process, to learn user impressions of these changes that we were going to make to their processes, and then really just understand how it impacted our physical space and hear general lessons learned. Next slide. All right, so about our center, this was at one of our hospitals in urban St. Louis County, a large endoscopy center. We do about 25,000 procedures here per year. We have 64 different endoscopes, primarily Olympus, and we're going to delve into that a little bit. We had 8 endoscopy techs who are responsible for all the scope processing that were involved in being trained into this technology. And as you can see in this diagram on the right, we have a 2-room process. So the scopes come into the decontamination room as shown at the top. We have 4 distinct manual cleaning sinks. A lot of times all 4 of them are being used. Post-manual cleaning, there's a pass-through window that goes over to what we call the clean side, where we currently have 4 AERs, each of them able to hold 2 endoscopes. And then high-level disinfection is done in this room, and the scopes are carried out to our scope cabinet, which is in a restricted hallway immediately outside of the clean side of the room. So that was our current state, and go on to the next slide. So for this evaluation study, it lasted 1.5 weeks and it was just earlier this year. And our goal was to get through 30 sterilization cycles. So as I mentioned, all Olympus endoscopes, we used several different types and models that are listed here for you, but included video gastroscopes, video colonoscopes, as well as duodenoscopes. We did have at the elbow support from the vendor for this entire evaluation of the study, and we'll talk about what that meant for us. But it was very helpful to really understand the technology itself. And then we did some post-study evaluations with our teams. So first, I'm going to talk about how we changed up the workflow for those 30 endoscopes that we sterilized. So the manual cleaning was exactly the same. Scopes were used in the procedural rooms. They were brought into the same spot of the room. We used those 4 manual cleaning sinks in exactly the same way. For the sterilization technology, as mentioned, we need to do some drying before putting the scope into the casket to do the sterilization step with. And we thought it would be important to have that drying done over on our decontamination side, since the scopes had been decontaminated and cleaned, but not had any sort of disinfection. We didn't want to be blowing that air around the side where we still had some of our AERs working as well as that sterilizer. So we installed a very small, very temporary drying station up in that decontamination side of our process. Post the 10-minute drying, as described earlier, we passed through, and then in that clean side of the room is where our techs used all the connectors to connect into the rigid container, ran the sterilizer in that room for that full 40-minute sterilization time frame. And then the sterilization casket, rigid container, was carried out onto a storage shelf, which also sat in that access controlled hallway right outside of our clean side. So what was different? Timing and physical space were 2 of the biggest things that we wanted to know and learn a little bit more about. So when you compare the turnaround time for a sterilized scope versus one that was automated HLD per our current process, it was very similar. I will say we had the benefit of some recent upgrades to our endoscopy center. So we do have one of the automated drying cabinets. So the 10-minute drying time prior to sterilization that required our techs to actually be sitting there doing the 10-minute air blow through was different for our techs because they were used to taking the scope straight from the AER into our automated drying cabinet. So it was an additional 10 minutes of time that our techs had to be engaged in the process, but didn't add any change in turnaround time overall for the process. When we think about timing, we do worry about having to redo. And so we, within this study, we did suffer 2 cycle abortions where we had to restart the sterilization cycle, one due to excess moisture in the scope and one due to our failure to follow the IFUs. And that was felt to be similar to the restops and restarts that we see with our current AERs. From a physical space, it was also pretty similar for us. The footprint of the sterilizer, which holds only 1 scope in its current modality, is a little bit smaller than our AER. So we would need more space to hold 8 sterilizers if we were to completely switch away from our AERs over to sterilizers. The other big difference or small difference was that the sterilizer did produce a bit of heat. You could sort of feel it as you were standing next to the sterilizer. So we noted for our future use that we would need to definitely address HVAC and have cooling abilities if necessary with, again, the idea of 8 sterilizers in 1 room. The rigid containers, they hold a similar footprint of storage to the cabinets that we had the rigid containers sitting on was a similar footprint to our current drying cabinet. So we wouldn't need more space to store sterilized endoscopes than we currently take up with storing our high-level disinfected endoscopes. You would have to clean and disinfect the rigid sterilization containers in between uses, and that's the same as the containers that currently hold and carry our high-level disinfected endoscopes. The process of disinfection was the same. Knowing what we know about sterile processing and sterilization caskets, it would be lovely to have a cart washer available to do some of that, but we don't have that, again, for our current endoscopy high-level disinfection process, so no difference there. And then, as mentioned, we had forced air dry. We would have to put forced air drying into that decontamination side. We actually had it over on our clean side from the process that we used before our upgrade to our automated drying cabinets. So we were able to move it over to the other side. But that is definitely a space for drying in a place that you felt is safe for drying would be a difference for ours. Our study was not intended to do a deep dive into cost estimates, but we offer just some thoughts about it. Capital purchase, of course, for sterilization equipment. If you were moving from an AER to a sterilizer, it would be a new equipment purchase. If you were at a spot where you're going to have to buy new AERs anyway, it's pretty similar. As mentioned, the connectors within the sterilization container are single use, so there is some consumable cost there. And then we also just discussed the fact that rigid containers do have a cost at purchase as well as a small maintenance fee. The scope group was pretty excited about some of the advantages. One of them is that this current vendor has a 6-month expiration of sterility. So many of us who are high-level disinfecting scopes are reprocessing scopes regardless of use at something like 4, 7, 10, 14 days. It varies quite a bit. With this center, we didn't have a lot of scopes that didn't get used. We were doing every 7 days. We are doing every 7 days. We didn't have a lot of scopes that didn't get used at least once, but they still felt it was notable that there will not be the need to reprocess everything every week. And then also, again, not a full in-depth analysis, but we know AERs have a lot of requirements for plumbing, drainage, filter maintenance. And it seems that the amount of space and the amount of things necessary for this sterilizer was quite a bit smaller. The survey results were very positive. We did a Likert scale 1 to 5, and I pulled out just a sample of them for you all to see. As far as how well the user's guide was to follow, they gave it a 4.8 out of 5. The connector assembly process they thought was very easy. The overall process of using the sterilizer was a 4.6 out of 5, and the overall rating of the Stereoscope system was 4.7. Pulled out just a few comments. They really enjoyed being part of this, giving this a try, understood really what this can mean to the safety for our patients in the future. So in conclusion, just a couple of additional things to add. We didn't trial the process of taking the sterilization containers to the procedure rooms. We currently have a very nice process where we take the high-level disinfected scopes into the procedure rooms. We thought it would be very similar, so we went ahead and when we were ready to use a sterilized scope, just pulled it out of the casket, put it in our currently existing rigid container for taking to the procedure room. So there might be some small difference in that process that we didn't assess. We also weren't able to assess retention of training on this process as we had the vendor there for the entire study. However, we would think it'd be similar to what sterile processing does with their sterilization processes. And then overall, there wasn't a ton of differences for us from moving from high-level disinfection to sterilization. That is partly because of the setup that we have with the automated endoscope drying cabinets and the AERs. So a center that was moving from a different sort of current state may need a very different footprint or a lot of changes. Overall, as I said, the study was a success. We were really excited about the opportunity to move this into some of our newer areas in the future.
Thank you, Kathleen. All right, so now at this time, we have 5 polling questions that I'll go ahead and launch for you all. And then after that, we will dive into the questions that anybody might have. All right. So I'll let you all go ahead and read these. And if, in case it doesn't show, 1 is strongly disagree and 5 is strongly agree. But I'll just give this a couple seconds for some more people to answer. Awesome. I'm going to go ahead and end this poll and go over to the second question. All right. And then over to our third question. All right, and I've got 2 more questions for everybody. Here is the fourth one. That's great to hear. A lot of you are interested in learning more. I will be reaching out to quite a few of you. All right, and that last poll question. All right. Thank you, everybody, for your responses and for participating in the polls. Let me take a look into the Q&As. And then if anybody has any additional questions as well, there is a Q&A tab. It should be at the bottom of your screen. So if you guys have any questions that you would like answered by anyone specifically or just by the team in general, go ahead and drop it down in there. Okay. Let's see here. I'm going to go ahead and read out one of these questions, and Dr. Rutala, Dr. Donskey, and Kathleen, if you'd like to go ahead and answer it, just feel free. So one of the first questions was, in real clinical use conditions, how many times have you sterilized each scope on the Steriscope without damage to the scope? Have you studied the scope after weeks to see if there were damages over time?
So we have not done an extended evaluation, but we used one scope for the testing that we did. We ran the scope probably 25 or 30 times, I'm guessing, and did not see any damage to the endoscope. I think more information is needed, but at least in our limited evaluation, we didn't see any damage.
And Dr. Donskey, another question for you. Where were the test strips, the chemical and biological indicators, placed? Were they placed in the bind or in the scope?
They were placed inside the container, but outside of the scope itself. So the microbiologic testing was inside the scope, but we were just assessing the container for the indicators.
Thank you. Dr. Rutala, this is for you. Somebody mentioned they were at APIC several years ago when it was stated that there was no way to sterilize scopes. This was prior to COVID. What has changed since then, especially for duodenoscopes?
I'm not sure who made that comment. Certainly, since approximately 11 years ago, when we published a paper in JAMA, we have been encouraging the transition from high-level disinfection to sterilization. Of course, it is challenging to sterilize endoscopes with long, narrow lumens, but certainly it's not impossible, as demonstrated by the fact that Dr. Donskey has done studies and published those studies in infection control in 2025. And of course, the fact that the FDA has cleared this technology using their definition of sterilization, which again is a 6-log reduction of a half cycle with no soil and a 6-log reduction of spores in simulated use with soil, and that was with a full cycle. So certainly I believe it is possible to sterilize endoscopes as represented by the current data.
Thank you. Another question, this could be for both Kathleen and Dr. Donskey. Were scope buddies used on the decon side?
They were during our trial.
Let's see here. Bill Wong, feel free to hop in if there's any questions you'd like to answer specifically. I'm just trying to go through all of them.
Sure. There was a question about, will Ideate Medical be expecting endorsements or acceptance from of Steriscope from Olympus, Fujinon, Pentex, and other manufacturers? We are working with major MDMs as we speak.
Let's see here. Or go ahead.
No, that's pretty much it.
Okay. Deborah had a question. Can this be used with scopes with multiple channels? I can go ahead and answer that. Yes, this is for scopes with 0 to 8 channels. So your most complex scopes are able to be processed. And each individual channel will have a connector connected to it. Steve had a question. What is the BI read time, and is it once a day or per load?
I think I can take that one. It depends on the policy of the hospital. It can be once a day for each system or per load.
Emily added, was there any damage to scopes in a rigid container with it being metal?
We looked and did not identify any.
We did not either.
Thank you. Do the scopes need to be stored in the reprocessing department, or can they be brought to other departments until use?
I guess I can take that one. They're already in a sterile container, so they can be stored in any department or any location that's appropriate, as long as you don't crack the lid.
I'd just add in, that'd be something to definitely discuss with your IP department, ensure we're following AAMI guidelines, et cetera, for storage of sterilized items.
Doe added, are there any adherences to manufacture IFUs?
Currently, go ahead.
Go ahead, Bill.
Currently, we work, as it's very similar to a previous question, we are working with key MDMs to get our device onto their IFUs. Obviously, that's a long process, but I think it's AAMI ST58 basically allows us to basically support use of our system with your devices per our validation testing.
And to that point, Bill, the new FSHEA guidance on high-level disinfection and sterilization says essentially the same thing. There's a comment in the first section of that document that says, if the manufacturer of a device did not validate the process, but the manufacturer of the accessory specifically validates the process for the device, or vice versa, the process is acceptable. So it doesn't have to be both, for example, the endoscope and the sterilizer. It has to be, for example, the sterilizer having validation from the FDA without having validation from the endoscope manufacturer. Because as you can imagine, sometimes there's a conflict because the endoscope manufacturer may have a high-level disinfection automated endoscope reprocessor that they may favor for reprocessing their scopes. So it's sometimes in not the best interest of the endoscope manufacturer to accept other technology. So it's been circumvented by ANSI, AAMI, and the new FSHEA guidance document using that verbiage.
Just for everyone's knowledge, the slides will be sent out. I got a question on that. The slides will be sent out post-webinar. Bill, this is a question for you. Bill Wong, what is the maximum height and diameter of the lumens?
The maximum diameter, well, we have a minimum diameter of 1 millimeter, and that's good for a length of 3.6 meters. Then a minimum diameter of 1.2 up to 4 meters. The maximum diameter can be 6 millimeters, which is typically one of the larger lumen channels that you might find in a endoscope where you have a buddy system, a buddy scope. So.
This is a great question. Were any of the processed endoscopes looked at with a borescope to see if there was any internal damage from sterilization?
Not in our study.
No, I don't think we actually used a borescope for any of that. We did have scopes after a lot of our testing go back for evaluation, but there are no issues within the actual lumens channels themselves.
I know we've got just a couple minutes left. And for those who have asked questions, if we aren't able to get to them, I will be reaching out to make sure any additional questions are asked, as well as if anybody has questions that you didn't feel like putting in the Zoom link, the QR code at the bottom of the screen or the email, feel free to reach out and we'll be able to, have any discussion you guys would like with any questions that you have. Let's see, Kathleen, this is a good question for you. How much did it slow the overall flow in a busy site?
So I was actually reading that as well, and I think there were some questions about whether or not additional cleaning needed to be done. No, we did not feel or identify a significant change in the amount of time. It was about the same the amount of time that the scope would have had to spend in the AER or in the sterilizer. And the connection process was pretty quick once you learned it.
Carmen had a great question. The drying station that was used, was this technology that had to do each lumen manually, or do you have connectors that allowed it to be more automated?
Bill, we did each lumen manually, right?
We did each lumen manually, yes.
Yep. That would certainly be an opportunity to improve this process. Again, that was a very temporary thing that we put into place for this 30 scope trial. So there are some opportunities for improvement with how we did it.
Joan had a great question. Are there any occupational risks? Anybody can answer this.
I guess I could try and take a pass at it. One of the beautiful things about any hydrogen peroxide sterilizer, when you really think about it, the only requirement for the system is really electricity to run the system. Typically, all the VHP sterilizers or hydrogen peroxide sterilizers have to pass a validation test that is submitted to the FDA that shows that the system's safe to use. That's when you open the door. Your byproducts are typically water, vapor, and oxygen. So you have to show that there's no residual peroxide vapor literally left in the system. And basically, that's a standard requirement. So our byproducts are oxygen and water vapor.
Thank you, Bill. I know we are coming right up on time. Dr. Rutala, Dr. Donskey, and Kathleen, are there any questions that you've seen that you'd like to go ahead and answer before we wrap things up? Or Bill, for that matter, too, if you see any questions that you'd like to address.
Let's see, I'm trying to scan the questions. I think there was one question about in our testing, did we use new or used flexible endoscopes? Just to put it in perspective, we probably did more testing of endoscopes from the key manufacturers than probably any other device out there. This was actually driven by the FDA. So just to be very candid, one of the things we wanted to do was actually test more with used endoscopes, because really that's really what's happening in industry, right? Everybody has used devices. So most of our testing, even our material compatibility testing and our life testing, it was done with used endoscopes. Obviously, as we transition and working with the key MDMs, they're supplying us with new endoscopes to test. So for us, that's a pleasant change.
I do have one additional question that I wanted to address, and Bill, you can tag on to this as well.
Okay.
Isn't hydrogen peroxide gas plasma a respiratory irritant? I can go ahead and take that. The bottles are sealed, so whenever they are put into the system, they are completely sealed. There is a tiny little needle that will poke through that will pull out the hydrogen peroxide, but it won't be exposed to anybody using it.
And as I mentioned before, we actually have to pass the OSHA study. So basically, our residual level from our system is about 1 ppm of peroxide, which is way below the OSHA limit. And that's actually very stringently tested, and that data is submitted to the FDA. So really, when you really think about it, we believe our system is far safer than an AER where you're exposed to aldehydes and peracetic acid.
All right. Well, I know we are over time. And again, for people whose questions we didn't get to, we will make sure to reach out to you and address any questions that you have. Thank you, everybody, for your time today. We really appreciate you joining us. And like I mentioned, the slides will be sent out from APIC post-webinar. I'm not sure the timeline of that, but I'd expect it within the next couple of days or so. And again, if you have any questions, feel free to reach out, and everybody have a great day, and thank you for your time.